Today I'll be talking on updates on IAH. So my previous speaker had made my job very easy. So I'll be going through some slides. So today we'll be mainly be focusing on the treatment strategy of IAH. So coming from the case scenario, a 23-year-old woman came with abnormal BMI who had an RTA without LOC. She had severe headaches after the RTA, transient visual obscurations, and tinnitus. Ophthalmological examination showed bilateral papilledema, MRI was normal, LP showed a CSF opening pressure of 32 centimeters of water. So what next? So let's go. So IH, we know it is very, very common in childbearing age, which is more frequent in obese women. It is no longer called benign because it can cause visual function loss. So it is replaced with IH term. So risk factors, again, obesity and systemic illnesses, endocrine disorders, few drugs, systemic illnesses, connective tissue disorders, and autoimmune pathology can also lead to IAH. So these five factors can contribute to IAH, that is obesity and weight gain, endocrine disorders, hormonal, venous sinus stenosis, and glial neurovascular interface. So this one slide already it was said in view of the obese woman who has truncal adiposity, which is leading to subcutaneous adiposity and omental adiposity transfer. There is a fat, so which will lead to increased leptin secretion, and all the hormonal factors can affect, which is leading to insulin resistance, which can raise the intra-abdominal pressure, and it can raise the intracardiac filling pressure, which will lead to the intravenous pressure leading to IAH. So I'm skipping these slides, which I've already told. So symptoms and signs already sir has told. So main features, headache, tinnitus, blindness, transient visual obscurations. Other rare symptoms also can be presented in IH, which should not be missed. That is olfactory dysfunction, cognitive dysfunction, and seizures. So all the first symptoms like headache, tinnitus, temporary blindness, and transient visual obscurations can be precipitated in forward bending and Valsalva maneuver. So we know the grades of papilledema. I don't want to repeat because everybody is hungry. Yes. So coming to the visual field charting, initially the patient can have inferior nasal portion, that is the peripheral field can be affected. Later on, there is a constriction of visual field until very late. So we know the diagnostic criteria. So now, which I'm going to focus on is IH without papilledema. This is the gray area now. So IH with papilledema, we know the patient is going to have a papilledema with normal neurological examination except the sixth cranial nerve palsy. Neurological imaging was previously discussed, normal CSF constituents and elevated CSF opening pressure. That is the criteria for IH. So coming to IH without papilledema, we are going to have everything from B to E except the papilledema part. That is very, very important. So how are we going to diagnose such cases? If the patient presents with persistent headache and the visual fields are going to give any clue, we can do a CSF opening pressure and see. So continuation of the case scenario, she was diagnosed with IH, but in view of worsening of papilledema, she was referred to higher center. On examination, her visual acuity was 20/15 and she had grade 4 and grade 3 papilledema on her both eyes. Visual fields had enlarged blind spots. MRI was repeated. Her previous MRI was normal. So don't hesitate to repeat the imaging when the patient is having a severity of symptoms. So her repeat MRI showed venous sinus thrombosis, that is superior sagittal. So hence we should not miss secondary alternating diagnosis. And as madam told, IH should not be over interpreted. So what are the gray areas in IH? That is already told. IH without papilledema. It can be secondary to the anatomic compartmentalization of the subarachnoid space around the optic nerve, stopping the CSF pressure gradient from reaching the retrolaminar portion of the optic nerve. Second is CSF leak. Sometimes post-op patients can have a CSF leak, which will decrease the ICP and it will mask the IH. So what are the diagnostic dilemmas we should rule out? invariably rule out other structural causes, tumor, SOLs, blockage of CSF absorption, other head injury following the patient is having a head injury, choroid plexus tumor. All these should be ruled out before patient labeling the patient as IH. So in neuroimaging, I'm skipping. So other ophthalmological investigations, perimetry, fundus autofluorescence, ultrasonography to rule out pseudopapilledema. OCT can also give the clue, thinning of retinal ganglion cell layer and inner plexiform layer, which can correlate with the severity of vision loss secondary to the optic nerve damage. So this is the main focus of our topic today. Principles in management of IAH. That is, we have three things: disease modification, damage mitigation, and supportive care. So what is coming to the disease modification? So we know that obese, weight gain people is going to have IH. So how much weight to lose? It is very a controversial topic and uncertain. If the patient has a BMI of more than 30, weight loss is definitely recommended and the target is 15%. If the BMI is more than 35, we have to give the option for bariatric surgery. So the role of acetazolamide in IH treatment target, which is conducted as a largest randomized control trial and which shows there is an improvement in visual loss and it is having a very good effect. The doses targeted is around 4 grams per day, but mostly in Indian scenarios, 4 grams is not tolerated. The patient can have some side effects like paresthesia, dysgeusia, vomiting, diarrhea, malaise, fatigues, all those things. So those people who are not tolerating acetazolamide, we can use topiramate for them, which is a weak carbonic anhydrase inhibitor. And the dosage will be starting from 25 mg per day to 50 mg. Later on, it can be titrated 100 mg twice per day. It has a similar efficacy to acetazolamide. Also, in patients who are having IH, who has persistent headache, sometimes migraine also be a coexisting feature. So you have to be very, very cautious. So in those patients, topiramate will be a very good choice. And also in obese people, it will also have some other advantages like a weight loss. So role of therapeutic lumbar drainage in IAH. So we are not going to advocate the patient on long-term serial lumbar punctures because it can cause exacerbation of the headache following the LP, which is secondary to the position. The headache only improves in 71%, but the improvement is very small. So there can also have a rebound headache in serial lumbar puncture patients who are likely to fail medical therapy. That is male patients. Male patients, we usually don't come across IH. It's very rare. Severe papilledema since the beginning, reduced visual acuity at the presentation are mostly likely to fail the medical therapy. So we're coming to the fulminant IAH, less than 4 weeks, the patient is going to develop rapid development of visual loss. So the rapid symptoms can progress within 4 weeks. The patient can have severe papilledema, grade 3 or worse, and visual acuity will be very, very low. And the patient can have 30 or more transient visual obscurations per month. So what we should do, we need to manage the patient very aggressively. So how aggressive? Acetazolamide should be started very immediately. We can titrate the dose and we can put the patient on serial lumbar punctures. Sometimes high dose corticosteroids are also recommended. That is methylprednisolone pulse followed by oral, and serial lumbar punctures can be planned until the surgical option is decided. So the role of surgery. Surgical interventions are warranted to salvage the vision. So the role of surgery for headache improvement is again doubtful. So don't put the patient for surgery for isolated headaches alone. That is very, very important. So what are the interventions we can do? One is the shunt procedure, optic nerve sheath fenestration, and the third one is transverse sinus stenting procedure. So optic nerve sheath fenestration, it is a very effective procedure who will have progressive vision loss despite medical therapy. It is approached by a medial orbital cut. The optic nerve sheath is identified and a window is cut in the sheath, allowing CSF egress into the orbit. So this will have immediate recovery on the same day, releasing the pressure. So this is a slide showing the surgical incision of the optic nerve sheath, a connective tissue lining surrounding the optic nerve to release the pressure on the optic nerve. So what are the complications of optic nerve sheath fenestration? It can have a transient diplopia, efferent pupillary dysfunction, secondary to the ciliary ganglion damage. Vision loss is usually transient but can be catastrophic, and vision loss can result from other vascular complications like central retinal or branch artery occlusion, choroidal infarction, trauma, optic neuritis secondary to infections, orbital hematoma, hemorrhage into the optic nerve sheath. So can also be a relapse of the pressure. So what are the controversies? So the main controversy is to do a diversion procedure or a stent. Both have equal advantages and disadvantages. So do not advocate CSF diversion or shunting techniques to treat isolated headache symptoms alone, because the patient can have a poor outcome. Ongoing headaches can be present in 68% at 6 months, 77% at 12 months, and so on. So no routine recommendations for the same, and there may be a role in highly selected patients only. So the how to choose the patient for stenting: visual threat, intolerance to maximum medical therapy, stenosis gradient more than 8. So some new emerging techniques for IAH. There is a role of GLP-1, which is now used in diabetics. We all know it will regulate the insulin secretion, weight loss. It will also reduce the CSF secretion. The second will be 11 beta hydroxysteroid dehydrogenase type 1, which will convert the inactive cortisone to active cortisol. And also it has been shown to reduce intraocular pressure. Other few therapies can be furosemide. IV furosemide has been used in many studies. Then amiloride, octreotide, all those things are used but has not been approved yet. So what about in pregnancy? We all know in pregnancy, acetazolamide and topiramate is absolutely contraindicated because of the teratogenic effect. So what can we do? We can do a serial lumbar punctures in the pregnant women. Ask the patient to reduce weight prior to planning of pregnancy. So how to monitor this IH patient? Recurrence and long-term monitoring. Recurrence of symptoms may occur in 8 to 38% of patients after recovery from an episode of IH or after a prolonged period of stability. So for patients with grade 2 papilledema or higher, we have to examine them quite frequently for a few months or several months, depending upon the amount of visual loss and the duration of stability. Who has grade 1 or minimal visual loss, we can follow up them annually or biannually, and we have to monitor them. So this is a very good flow chart. We can come. So coming to non-fulminant IAH, maximum medical therapy, progressive visual loss with or without minimal headache. So what we can do? Optic nerve sheath fenestration. If the optic nerve sheath fenestration is okay, we will leave it. If the patient is having a progressive vision loss, we can advise the patient for CSF diversion procedure. In patients with predominant headache without vision loss, we can do a diversion procedure. That is lumbar puncture with opening pressure, again a diversion procedure. Headache or vision loss, both are there. We can go if the venous sinus stenting, if the stenosis is gradient and very high, we can go for sinus stenting. So if the headache persists or progressive vision loss is there in spite of all these treatments, check the functional status of this shunt, whether we need any revision or any replacement, or the patient can even develop a meningitis, meningeal signs secondary to the shunt infections, all those things. If the patient is prolonging to have a continuous visual loss, we can try optic nerve sheath fenestration. What about in fulminant IAH, lumbar drain, till we are going to plan for a surgical option, headache again with or without visual loss, say a CSF fluid diversion, visual loss with minimal or no visual loss, optic nerve sheath fenestration, severe headache, we can go for diversion procedures. So coming to the summary, IH, those who have all slept, these 2 slides are enough. IH is a syndrome of increased intracranial pressure of unclear etiology that most often occurs in obese women of childbearing age. Common symptoms of IH will include headache, transient visual obscuration, pulsatile tinnitus. Papilledema is the most common and important clinical sign. If untreated, can go into irreversible vision loss. Optic atrophy is there. And the management will include weight loss, medical therapy, and surgical interventions, which is already discussed. The management approach should be tailored for each patient. It is no hard and fast rule we are going to have. And which will be according to the severity of vision loss, severity of papilledema, severity of symptoms, and response to medical therapy, and ability to tolerate the medical therapy. So take home points, the management approach for individual patients with IH. The management approach for individual patient with IH depends on the severity of vision loss based on formal perimetry, severity of papilledema based on the grade of papilledema. The patient with mild vision loss can be managed with weight loss and medical therapy. Patient with moderate vision loss can be managed with weight loss, aggressive medical therapy. Although the surgical intervention could be considered depending upon the response to the weight loss and medical therapy. With severe vision loss will require a combination of all the three, and the timing and the surgical option should be very, very important, and it remains very controversial and based on the availability. Patient with IAH require long-term monitoring because it's a chronic disease and large chances of relapse is possible with weight gain. The severity of vision loss, papilledema symptoms influence treatment decision. So it is a co-management between the ophthalmologist, neurologist, and neuro-ophthalmologist for better treatment plan. Thank you.